recording has started. Paul, handing over to you.
Thank you very much. Can you, I don't know, hopefully I'm sharing my screen. Can you see it?
Yes, we can see it. It looks
Okay,
perfect.
that's good. Okay. And I realize we are few, so I'm very happy to be informal. So I said some questions in the chat, but I'm very happy to be interrupted if anybody wants or has particular issues you want me to address. Otherwise, I'll just work through what I've prepared. And I know you're recording this anyway, so hopefully it'll be of use to others. So by way of background to me, I'm a solicitor and partner at Enable Law. Enable Law is quite a big South West law firm. We're part of Foot Anstey. We have offices down from Bristol down to the tip of Cornwall, and down to Southampton and London as well. So we're quite sort of South England based, really. And at risk of making myself a deeply hated person, I only act for claimants, so only act for patients. So if you're dealing with medical negligence work, you either have to be one side of the fence or the other. But I always think it's quite helpful for medical professionals to hear from somebody who acts for patients, because you get a slightly different perspective. So what I'm going to talk about is consent to medical treatment. And 10 years ago in March, so March 2015, the law changed quite significantly, and the change caused some ripples of anxiety through the medical profession, because the law redefined, the courts redefined what a medical professional's duty is when it comes to treating patients in terms of giving advice and obtaining consent to treatment. So it's that I'm just going to run through. Hopefully I'm going to demystify a bit, and hopefully I'm not going to frighten anybody with this, because I think the law's probably less demanding than people fear it might be. So the law changed with the case of Montgomery and Lanarkshire. So this is Nadine Montgomery. She's quite an interesting character, very sparkly woman, who has, as a result of this case, actually, she's qualified as a solicitor. She's now working in the legal profession in Scotland. The case concerns their son, Sam, who, when the case went to trial, was 14, 2013, is now, you can do the maths, 26, I think. So Sam was Nadine's first child. He was born in October 1999. And Nadine is an intelligent woman, and I say that not to belittle in any way, but she had a degree in biomedical science, since become a lawyer, and the significance of that is that she was well able to understand medical advice that she was or should have been given. The birth was at higher risk than average of being complicated by shoulder dystocia, so shoulder getting stuck in the pelvis, potentially causing an injury to the mother. Also, a small statistical possibility of an injury to the child, but the risk of a very serious injury indeed, so risk of an ischemic injury causing brain damage. And the reason she was at such high risk is that she suffers from type 1 diabetes. She was also quite short, she's only about 5 foot high, and she had a whopping great big baby. So the risk had gone up from, I think, around, obstetricians would say it's around 1% or just a little bit below that, to 9 to 10%. So quite a high elevation of risk. The obstetrician who managed her delivery, well, I put in that slide obstetrician's advice, which didn't really give any advice. So the alternative ways of managing the delivery were either normal vaginal delivery or caesarean section. Only 2 ways to have a baby, I think, really. And she advised Nadine Montgomery to go along the route of vaginal delivery, didn't tell her about the risk. And the reason she didn't tell her about the risk is that, as the obstetrician said when she gave evidence in court, if she had done, she would have expected most women in Nadine's position to elect the caesarean section. So just pausing for a moment, she didn't give the mother the advice that she thought would change the mother's decision as to how the birth should take place. And the reason she didn't do that is because, as she put it in her evidence to the court, it wasn't in the maternal interest to do so. Now, if you just sort of pause and think about that, that's a slightly puzzling thing to say. Maybe slightly is the wrong word. Maybe I shouldn't have said that at all. It's a puzzling thing to say because who is the obstetrician really to decide what's in the mother's interest? If you're a patient being treated by a medical professional, the medical professional can give you advice as to what your condition is, or how it should best be managed or treated. But to determine what's in your interest really isn't it for you as a patient to do that? So a rather surprising approach, and a rather paternalistic approach. And of course, inevitably, otherwise this would never have become a famous legal case. The birth was complicated by exactly that problem, by shoulder dystocia. Sadly, Sam suffered a hypoxic injury during delivery, and he was left with cerebral palsy. So Nadine brought a claim on behalf of her son, and the claim was that birth had been managed negligently, and that she was wrongly advised. At least she wasn't really advised at all, in that she wasn't told about the risk, and that she wasn't told how to avoid the risk. The case went to this rather, I could be rude about this court because I have Scottish ancestry. The courts in Scotland are very dour, and the judges are very dour and conservative. But it went to this rather dour court, the Court of Sessions in Scotland, and the rather dour judge decided that there was no negligence in the way that birth had been managed perfectly appropriately, and the fact that Sam suffered an injury was just misfortune, which of course happens from time to time. But rather more surprisingly, the judge found that the advice, or rather the lack of advice to Nadine, was entirely adequate. So it was absolutely fine for an obstetrician not to tell her of the risk that would have changed her view as to how the birth should have been managed, and given her the option to avoid the risk, basically, and stop something awful happening. And the reason the judge came to that view was that he heard evidence that was in line with what other doctors would have done. So other obstetricians would have failed to tell her about the risk and failed to give her the option. And that might seem rather puzzling to you, but the reason the judge came to this decision is that he was following the law as he understood it and applying the Boland test. Now, the reason I've talked you through this case is that I always think it's quite helpful when you're trying to understand the law. It's quite helpful to try and understand the cases that gave rise to that law, because it puts the whole thing in context. So now I'm going to tell you about the case of Boland and what the Boland test is and why we've got it. So here we go back to 1957. In fact, we go back to 1954 because Paul Mr. Boland suffered his injury in 1954, and in 1957 his case came to court. But the 1950s, sort of assume everything was in black and white in the 1950s. And this picture rather reminds me of anyone who's ever seen the film Carry On Doctor. I always think of Hattie Jakes as the matron in this. But anyway, sorry, let's go back a bit. Paul Mr. Boland suffered from bipolar disorder, and he was treated with a form of management, which I think very proud to say was developed in Bristol, which is electroconvulsive therapy. Now, I might not have got this entirely correct, but my understanding is that with electroconvulsive therapy, a huge electrode is put either side of the head, and somebody throws a giant switch. Electricity pulses through the patient's brain, inducing seizures, and can be very helpful in treating bipolar disorder. Well, in Paul Mr. Boland's case, not a man who enjoyed great fortune in life, really. The effect of the electric current pulsing through his brain was to cause contractions and seizures, and sent him flying off the table onto the floor, where he found himself lying now with a nastily broken hip, still with bipolar disorder, feeling that life had dealt him a rather bitter blow. And he brought a claim against the hospital who treated him, and he said, with medical evidence, so the court had medical evidence to say this injury was entirely avoidable, and the way it could have been avoided was by strapping him down to the table and by giving him a muscle relaxant injection. And a large number of doctors using electroconvulsive therapy would take those two precautionary steps to avoid injury to patients. But the hospital defended the claim, and they relied on evidence from also an expert who said, yes, all that is true, but there is a number of us who don't like strapping people down and giving them muscle relaxant injections, because there are risks to doing that, and we have to balance the risks and benefits. And we take the view that balance comes out in favour of not restraining and not injecting. And the judge said, well, I'm faced with a dispute within the medical profession as to how best to deal with this situation. And he said, where there's a dispute, we as judges are not going to get involved. We're going to step back and we're going to say that it's really for the medical profession to decide what is reasonable practice, and provided it's a reasonable practice, it's a responsible practice, we're not going to intervene. We're not going to say one is better than the other. So the judge defined the question for the courts in considering whether there's been negligence as this: has the doctor, so forgive me saying doctor, the same applies to all allied medical professionals, but this case was about doctor, has the doctor acted in accordance with a practice accepted as proper by a responsible body of medical, well, in 1957, the doctor said medical men. I don't think the doctor could imagine there could possibly be such a thing as a woman practicing medicine, probably because he'd spent his life at boys' public school and an all-male college at Oxford or Cambridge, but there we are. Has the doctor acted in accordance with a practice accepted as proper by a responsible body of medical men or women skilled in that particular art? Skilled in that particular art just means that there's a different standard depending on what your discipline is. So there's different standards for different types of doctors. There's a different standard for a GP than for an accident and emergency doctor or an orthopedic surgeon. There's a different standard for a physiotherapist and for a paramedic, depending on what your skills are and what your practice is. Grab myself a drink, but I seem to have left it downstairs. So the standard is reasonable care, and what's expected depends on your type of practice. And the court will not judge between different responsible schools of thought. Unless, and this is a qualification that came about 30 years later in a case called Belitho, unless the court finds that what is described as a responsible practice, in fact, lacks any great logical analysis. So it's a standard set by medical professionals. It is, in effect, to some degree, medical professionals are allowed to mark their own homework. So in the case of Montgomery, just going back a bit, in the case of Montgomery, the reason the judge said the advice given to Nadine Montgomery was adequate is that he heard evidence that there was a responsible body of obstetricians who would have failed to give any different advice, would have failed to warn her of the risk. So since the case of Boleyn, so Boleyn was 1957, paternalistic era, very long time ago, before I was born, and I'm sure before most people on the call were born. Since Boleyn, the tests have been applied to the three things that medical professionals do, which are to diagnose, at least in my view, the three things you do. Diagnosis, so deciding what someone's condition is. Treatment, working out what to do about it. But also the third thing, which is providing information to patients and giving advice and obtaining consent. But why should we apply to information and advice? So think about yourself as a patient, because whatever we do, we're also patients. When you go and see a medical professional, you're going to see your GP, say, for something's wrong with you. Your GP has hopefully the expertise to tell you what's wrong and suggest what can be done about it. But in terms of, and those are very much matters of medical expertise. So if somebody's criticising the GP and the judge is trying to decide whether what a GP did in terms of diagnosis or treatment is correct, the judge is going to need evidence, expert evidence from a GP expert to say what is expected in these circumstances. But when it comes to the nature of the discussion with the patient, should you need a medical expert about that? Isn't that more about understanding your patient, working out what's important to them, working out what their priorities are, helping them make their own decision? And is that something just of only medical professionals can do, or is it something we all do day by day, and judges can do, and I do in talking to people in my different contexts? So there's been a lot of criticism over the years as to the application of bowling to this whole business of having discussions with patients, providing information and advice. And well, the case of Montgomery case failed all the way up to the highest court in the land, which is the Supreme Court. Here's a picture of the Supreme Court. If you're counting carefully, you'll see there are 7 judges. No, there are 9 judges sitting. Actually count. I think it's 7 or 8 judges sitting there. Normally it's only five judges, but the only picture I could find of the Supreme Court was the court dealing with Brexit, I think, dealing with the prorogation of Parliament or something. Anyway, that's what the Supreme Court looks like. And when the case came to the Supreme Court, the judges restated the law in a new way. Now, what judges don't do, let me let you into a little secret. What judges don't do is change the law. They're not allowed to write the law. Only Parliament can do that. So what the judges do is restate the law, and they tell us what the law always was, although we probably never realised it. And that is indistinguishable in practice from rewriting the law. And what the Supreme Court said is, here's the starting principle. So an adult person of sound mind, so let's just pause there. So this only applies to adults, not children. And it only applies to adults of sound mind, which is a rather archaic legal way of talking about mental health difficulties and cognitive difficulties. So this is basically people who are able to manage their own affairs. Adults are able to manage their own affairs. A different regime applies to children and applies to people who don't have capacity to make these decisions. And that's all dealt with by the Mental Capacity Act. That's all about doing what's in someone's best interest. But the law here, the Montgomery law, applies to adult persons of sound mind. And we, to assume that we're all adult people of sound mind, we're entitled to decide which, if any, of the available forms of treatment to undergo. And our consent must be obtained before treatment. And when I first read that nearly 10 years ago, I thought, oh, there's nothing new in that. It's always been the case that if anybody's going to treat me, they need my agreement to do so. But actually, when I stopped to think about it, I realised there was something new and different there, and that's the words of the available forms of treatment. There's an assumption there that there's more than one way to treat any condition or medical situation. Even if the only options are don't do anything, no treatment at all, there's always an alternative between treat and not treat. And in Nadine's case, there was an alternative between, nobody could stop the process of birth, I suppose, but the alternatives were vaginal delivery or caesarean section. So there's an assumption of choice here. There's an assumption that there's more than one way to do things and that patients need to be empowered with choice. So, and the law is all about doctors. Not everybody listening to this will necessarily be a doctor. So substitute your profession. The doctor or the medical professional is therefore under a duty. So here's the duty. And it's a duty to take reasonable care. Now, a lot of people got very alarmed about the Montgomery decision, but I would emphasise that the courts only ever want people to do what's reasonable. Reasonable is a bit of a woody word that lawyers use a lot. And when I was first practicing law, I thought, well, what on earth does reasonable mean? How do you know? And I still don't really know the answer to it, but reasonable creates a grey area where there is scope for disagreement and difference. So there may be more than one way of doing things. There may be more than one opinion to take or path to take. But the court will say, well, there's often a number of different approaches, all of which are okay. So this is an absolute duty. There's scope for people to take different views and do things differently, but still be well within the compliance with their duty. So the duty is to take reasonable care to ensure that the patient is aware of any material risks. I'll talk in a minute about what's a material risk as opposed to just any old risk. Material risks involved in any recommended treatment. So what you're proposing for the patient, you need to make sure the patient knows the risks. You also need to tell them the benefits, but the court didn't really focus on that. But also the material risks of any reasonable alternative or variant treatments, bearing in mind there's always choice. And to enable people to weigh up their choices, they need to know the risks and benefits of both so they can weigh them up and decide what to do. So well, what is a material risk? Why is it just a material risk and not any other risk? Well, the court says the test of whether a risk is material, and therefore we need to discuss it, is whether, in the circumstances of a particular case, and this means every patient is different. Every patient, you need to think about every patient and think, well, what does this particular person, what applies to this particular person? So there's no real standardized way of being able to determine a material risk. In the circumstances of this case, this particular person, a reasonable person in the patient's position would attach significance to the risk. What does that mean? That sounds like lawyers gobbledygook, really, keeping us in business, but making sure that nobody else understands what on earth we're talking about. So the best way to explain what this means is by explaining what it doesn't mean. So the test could have been an entirely objective test. So when you go and drive your car on the road, the same standard is expected of you as of every other driver, be they a 17-year-old who only passed their test this morning, or a 99-year-old whose reactions are a little slower than the average, let's say. It's the same standard. And the court could have said, well, a risk is material if an objective, the sort of reasonable patient, any old patient would think it reasonable, treat us all the same. It didn't want to do that because it wants to have a patient-specific test. So that's the sort of objective test it rejected. On the other hand, it could have chosen a subjective test. He said, a risk is material if this particular patient thinks it's material. That's an entirely subjective approach. Well, if you're treating somebody, how can you possibly know what's going on in their brain? You can only guess what they're thinking, and a subjective test would be entirely impossible. So what the courts have done is tried to sort of find a middle position between the two. And it said, let's have a test that's as specific to the patient, this particular patient, as possible, but then let's put it through a sort of reasonableness filter, which realizes that, which recognizes the fact that you don't know exactly what's going on in that patient, but nevertheless, you're communicating, you're picking up signals, you're reading between the lines, and you're doing all that's reasonable to understand what they want. So the court said, well, let's take the individual patient and let's put them through a reasonableness filter. A reasonable person in the patient's position would attach significance to the risk. So if you think, knowing this person, it's probably a risk they would think it's significant, you've got to discuss it with them. There's an or here. I don't think this adds very much. The doctor is or should reasonably be aware that this particular patient would attach significance to it. So what that means is, if you wouldn't have guessed that something is really important to somebody, but you know it, you have to take it into account, and I can't really see why that's adding anything. So, you have a very, very elderly patient, she looks very frail, she comes to see you. You wouldn't have guessed, but she tells you that actually her hobby is trapeze, let's say, and you look at her and think, oh, I've never guessed that. Well, you now know it, you've got to take it into account. I think that's all this is saying. So just sort of stepping back again, we've moved from the very clinician-centered approach, the obstetrician who said, oh, this is, it's for me to determine what's in Nadine Montgomery's interests, to a very patient-centered approach. Well, what does Nadine think is in their interests? We've moved from, when it comes to advice and consent, but not treatment and diagnosis, we've moved from Bonham to Montgomery. The test has moved from being what a responsible body of medical professionals would advise, responsible body within a particular discipline, to what a patient like this would want to know. It's moved from a test where the medical profession sets the standard and marks its homework, if I put it, and to one where the patient sets the standard. This is all about the patient. And Bonham still applies to diagnosis and treatment, but the Montgomery test applies to information and consent. There are three exceptions where Montgomery doesn't apply. First is the patient who doesn't want to know about the risk. So you don't have to tell a patient about the risks if they don't want to know about it. If they don't want to know about it, I think it's probably pretty important to explore why they don't want to. One needs to treat this very, very carefully. But if you've explored that and they don't want to know, you don't have to tell them. Secondly, there's what courts call the therapeutic exception. That's where disclosing the risk, telling them of the risk, may be detrimental, seriously detrimental to their health. And I can only think, I mean, you'll know more about managing patients. I don't know about patients because I have clients instead. But I can only imagine this would be where somebody is very vulnerable in their mental health, and telling them about things that are just going to cause increased anxiety are going to do them extreme harm. But the courts did say, well, this exception needs to be construed very narrowly, so it can be very careful with it. And the third one is the unconscious patient role, necessity. It's where somebody, they're an adult, they're of sound mind, but they're not able to make a decision. They need urgent treatment. You don't have time to go through this process. Maybe they're unconscious. You just get on with it. So necessity is the third exception. I've asked the question, is this really about consent? People always, I'm often asked to talk about consent. And the question in my mind is, well, is that really the right subject? Because consent is only one stage, the very end stage of what should be a process of providing information and empowering patients to make the right decision for them. I think that's a much better framework within which to think about this. I do think thinking on consent, it is really looking at things through the wrong lens. What the courts really want you to do is empower people and enable them to make the best decisions for themselves. A few implications in practice, and these come from what the judges said in the Supreme Court. They say, well, the discussion with the patient is really, really important. The aim of that discussion is to give the patient the information she needs to make the right decision. The way I put it is empowering the patient. That means that you need to find out what's important to your patient, what's material to them. And the judges did warn that this may take longer. And I know doctors working in the NHS also threw up their hands in horror at the time and said, well, how can we do that? And the court said, well, we know that's a problem, but your administrators will have to deal with it. Patients need to be empowered. I just put down what to record as well. What I really, as something that's only for patients, what I really don't want doctors to do is spend their life worrying about claims and being defensive, I suppose, making notes because they think, well, I may need to defend a claim here. There's only about 15,000 claims a year, which isn't a huge number according to the NHS resolution. The number of claims, when you think about the amount of medical treatment going on in the country, it is far, far less than you would think, and probably far less than the number of things that are going wrong in people's medical care. And yeah, so I don't want to encourage, and sometimes dependent, I fear that dependent lawyers may do that. Lawyers at the hospitals may put the fear of God into medical professionals about how much litigation there is and how to be very defensive about it. And I really don't want to encourage people to do that. But the reason for making records is primarily so that you can support your patients and help other people who are seeing them to know what's going on, know what has gone on, and make the right decisions. But if you want to make sure that you're sort of recording properly, then my little tip is to record something the patient said, because the courts want to know not just what advice you've given, but what the patient wants. So putting something down about what a patient's concerns are, what a patient's priorities are, why a patient wants treatment to go in a particular direction, just suggests there's been a good dialogue there, and I think that's quite helpful. I want to address 3 common misunderstandings about consent. The first one is that it's all about percentages. So people are often asked me, when I speak about consent, well, what sort of percentage is a significant percentage? Is 1%? Is a risk likely to be material if there's a 1% risk of it occurring? And the answer is it's just not about percentages. Percentages are one factor, but they're only one factor. So the court in Montgomery said, it follows from this approach that the assessment of risk cannot be reduced to percentages. The significance of a risk and whether it's material might depend on its magnitude, how likely it is to happen. But it also might depend on the nature of the risk, how serious a risk it is, should it occur. And think about it, Nadine's risk of injury from shoulder dystocia was probably around, I don't know, there's a 9 to 10% risk of shoulder dystocia, probably around 1% or less of her being injured. But the risk for her baby was probably 0.1. It was probably a tiny percentage, probably 1 in 1,000. And yet it's a risk that if it occurs, it's a really, really serious one. It's a life-changing risk that's going to involve care and support for life. So it's not just about the likelihood of the risk, it's also about the seriousness of the risk, but it's also about the importance to the patient. The importance to the patient at the benefit of treatment. How important is it to have that treatment? Or, are there any, I've heard, I remember I was about to undergo a spinal surgery operation, a laminectomy, and I heard a talk from a pay manager who said, when things go wrong, it's so serious, I would not do that unless I was thoroughly incontinent and my feet flapping around on the floor, which is a little bit discouraging when you're about to have that operation yourself. But the point is that, if you've got really bad back pain and there's a risk that you might end up being doubly incontinent and paralysed, you might think, well, I'm just going to put up with this extremely serious back pain for life because I'm weighing the risks and benefits. Or you might think, well, the risk is so small, I'm going to run it. And this back pain is really intrusive. But it's for the patient really to decide that. And then, of course, the alternative. What are the alternatives? Are there other ways of managing the condition? So there are all these factors that come into the pot when it comes to thinking about whether a risk is material. It's not just about percentages. Common misunderstanding number 2 is that if you tell your patients everything, you've done your job, tell them every risk and then you're safe. Well, that is not a good solution. Because the goal of advice is to give the patient advice they can understand. Some people will be able to handle a huge amount of information, and some people simply won't. They'll just confuse them, they'll just feel lost, they won't be able to see the wood for the trees. Just after one of the first talks I did on consent, just after Montgomery, I spoke at a private vascular clinic, and I hadn't heard the previous speaker. I went in and did my bit, and for some reason I went off on one about an 8-page consent form I just read. And I said, what patient can possibly read an 8-page consent form full of small print and take it all in? Why would anybody in their right mind think that was a good way of advising patients? And it's one of those moments where I just knew I'd said something really, really wrong, because the people's faces just dropped and they looked at me with absolute horror. And I ploughed on valiantly, nevertheless. And after my session, somebody took me on one side and said, the person who spoke before you was the CEO of the vascular clinic, and he'd just taken us through our new 8-page consent form. So people do like these consent forms, but a lot of information isn't necessarily the solution for people. It's not necessarily helping them to understand. And as the court said in Montgomery, the doctor's duty is not therefore fulfilled by bombarding the patient with technical information which he cannot reasonably be expected to grasp. So third misunderstanding is that consent form is a get out of jail card, and that once somebody's signed a consent form, they've consented. Actually, it doesn't mean anything of the sort. If you think about a consent form, well, consent is a process. It's about empowering people, giving them the information they need, and that doesn't happen in a moment. It doesn't happen in the moment they sign the form. It's been happening in the process leading up to that. And also, when you look at these consent forms, they only cover a very small amount of what Montgomery says patients should be told about. So it might tell you that what the risk is, and it might tell you the percentage of it occurring. I've seen so many that say, bleeding 1%, infection 2%, pain unquantifiable. I don't know, but they don't tell you what that means. I mean, when you put pain on a form, what does that mean? Does that mean a little niggle, or does that mean a lifetime of disability? So it doesn't tell you very much. It doesn't tell you about the impact on your life, and it certainly doesn't tell you about the alternatives. And it probably doesn't tell you why you've chosen that form of treatment as opposed to another form of treatment. So to my mind as a lawyer, it tells you very little about what a patient knows, or whether they've really been advised properly. So I'm not very excited by consent forms. I don't say don't get your patients to sign consent, but make sure that your patients have understood, and that if you're asking them to sign a consent form, that there's much more documented that shows that you've given them the proper advice. And I just cited the case there. That's a case where somebody had signed a consent form. I won't tell you more about it, but the court said, well, despite signing that form, they hadn't consented. So, having provided everybody witness, then I just want to bring you a little advice from Bob Marley, which is don't worry about a thing, because every little thing is going to be all right. And this is from me as a claimant lawyer. I can tell you that cases based on consent from a patient's point of view are extremely difficult to prove. I've raised a few issues about consent in claims, but only alongside where there's been some other breach of duty in diagnosis or treatment. I've never run despite being an expert specialist in consent, I've never run a case solely on consent, and I probably would take an awful lot of persuading to do so. First problem with them is there's almost always in these cases a conflict of evidence, a dispute about what advice a patient was actually given. So sometimes hospital lawyers will tell doctors that if it's not written down, it didn't happen. That's complete and utter rubbish, because numerous times, I mean, the courts will understand that, we don't all note down everything we do. We don't note down all the advice we give, whether you're a doctor or whether you're a lawyer. You just don't have time. It just wouldn't be practical to do that. So the courts will assume that what they're seeing in the notes is the tip of the iceberg, and that there's a lot more. And quite often what doctors will say is, well, I don't remember anything about this particular appointment, but my invariable practice, and I didn't write it down, but my invariable practice is to do X, Y, and Z. And the courts will, that's a perfectly reasonable thing to say, and the courts are likely to take that at face value. So the first problem with them, from my point of view, is that where there's no documentary evidence to prove that something happened, I'm very unlikely to persuade the court that my client's account of events is correct. And the second is that it's not enough to show if a patient wants damages, they say they've been misadvised and they took a course of action, they accepted a form of treatment which went wrong, caused them harm. They will probably say, well, if I'd been advised differently, I would have chosen something else. And the difficulty with that is hindsight bias. So we all tend to think that had we been advised differently, properly, we would have done something different. But how do we know whether that's the case? And the courts will, it's really, really difficult to persuade the court that somebody saying that is not coloured by hindsight bias. So very difficult for patients to succeed on consent cases. So that's my Bob Marley advice. Don't worry about a thing. Just the last thing I want to finish with, and you'll be relieved to know that I'm almost there, is why is this all important? You might say it's really important because autonomy patient autonomy is a very important cultural value. I'm sure that's right. I'm interested in this research by the King's Fund back in 2012, so quite some time ago. And I don't say this in any way to denigrate anybody. I'm sure the same could be said of lawyers as of doctors. But one of the things their research found is that doctors regularly misjudge both what their patients actually want, their treatment preferences, and also what they want the outcome to be. So you might think, well, that's pretty bizarre. So a number of doctors were asked, in dealing with breast cancer, so I think it was breast surgeons were asked what percentage of patients prioritised maximum life expectancy over other outcomes. And when the doctors were asked, they said 96% of patients would prioritise life expectancy. When they asked the patients, it was 59%. So doing the maths there, it's roughly 2/3, just under 2/3. Every 3 patients they were advising and trying to do their best for life expectancy, 1 patient wanted something else, which is quite stark. But even more stark, when breast surgeons were asked what percentage of patients prioritise preserving the breast, the doctor's view came out at 71%, whereas the patient's view was only 7%. So they were getting it wrong for 9 out of 10 people. Now that I find absolutely extraordinary, but it does suggest that there can easily be a mismatch between what we as professionals think is important and what our patients, or in my case, my clients, think are important. And this is a bit of a sort of start wake-up call to me as well in my own work. Just sort of carrying on with this theme, the International Cochrane Review found that 20% fewer would elect for surgery if they were fully informed. So breast treating could save the NHS huge amount of money by ensuring people are better advised, because then there'll be less treatment. And one that interests me, because I sort of fall within the demographic, I guess, is men with benign prostate disease. So it's not prostate cancer, it's benign disease. Urinary function is a bit of a mess, frequency or hesitancy or something. What is more important to them? Is it sorting that problem, or is it preserving their sexual function? Because dealing with benign prostate disease may have an impact on sexual function. And 40% of men, when fully informed, 40% fewer elected for surgery. So 40% fewer decided that prioritise their sexual function over their urinary function. And this is sort of older men, which is the hope for the future, really. So on that rather optimistic note about what retirement might look like, not just about paperbacks, I'll stop there. And if there are any questions, I'm very happy to. I'm going to unshare my screen so I hope I can see you again. Is there anybody left? Has anyone had some left?
Yes, I'm here. I'm going to stop recording.